Good afternoon and welcome to today's program titled Addressing Increased Demand for Mental Health Services Through Mobile Technologies. I'm Shannon Bryce, Associate Editor of Behavioral Healthcare Magazine. Today's program is sponsored by Core Solutions. Thank you to our sponsor and to you and our audience for giving us your time and attention. Before we get started, I'd like to share a few housekeeping details. Each window on your screen can be moved by clicking and dragging, or enlarged and minimized by clicking the icons in the top right corner of each window. Please use the Q&A area to the right of the slides to submit a question at any time. If you cannot see this area, simply click the red Q&A button. To download a copy of today's slides, please click the link in the Resources area in the upper right of your screen. If you have any technical issues during the program, please click the yellow Help button to troubleshoot the issue. At this time, it is my pleasure to introduce our speakers, David Smith, VP of Technology, and Robert Capobianco, VP of Marketing for Core Solutions, Inc. Thank you both for taking the time to speak with us today, and with that, the audience is yours.
Great. And thanks, Shannon, for those introductions, and thank you, everyone, for attending this webinar today. We all understand that everyone's very busy, and to carve out an hour of your time, we just like the opportunity to present the material that we have today. So with that, before we get started, I think a good place to just get oriented is just to look at the agenda for today's webinar. We've already gone through the introductions, obviously, but we want to start with just a discussion around the market trends. From there, we're going to move into a high-level discussion around mobility for service channel expansion, and we'll get into how we define that as we get through the material. From that topic, we'll move into really a roadmap for mobility, which we've coined out as a maturity model for organizations, which essentially set up and start to think about the readiness from your organization standpoint. We'll move from there and go to a summary, and then we'll open up at the end for a question and answer period. So now that we've sort of got how we're going to move through the material, let's go ahead and get started. So the first place that we wanted to just talk about, and I think this, from the perspective of everyone here on the webinar, pretty common, thought in our industry is we're always facing changes. And when you think about it from, what we see here on the screen, we've had to deal with standards changes, and we've got another set of standards changes coming up if you're participating in meaningful use. If you're thinking about outcomes, ICD-10 really represents another code or a standards change. If you look further into the slide, we've also changed across in healthcare in terms of our settings, right? Even in behavioral health, we've, moved from much more of an sort of an institutional setting and a management of symptoms to a lot of organizations have switched their focus to much more on recovery and how do we keep our clients in the community and make them as positive experience, ability to contribute into communities as much as possible without sticking them into institutional settings. As you look further into the slide, I think we're all here and we've experienced the electronic changes in our industry. And I think mobility really represents not only a technology change, but an opportunity for us to think about this whole notion of how do we change the way that we deliver services. And mobility to us, from our standpoint and how we speak to it about our customers, is really an additional channel that you can think about on how to engage, interact, and share information with your clients or your population. So with that, I think, we are all, very well into this change, but let's think about mobility as that level of extending your service channels. Again, we'll continue to kind of drive home on that point, but we wanted to set the stage here first around, mobility as another change in our market. So behind those changes, though, there are typically these three areas in our industry as an organization themselves and technology that tends to give the driving momentum for change. And again, I don't want to belabor here the points that are on the slide, but I think it makes sense to spend some time in each level. From a policy standpoint, I think we're all very familiar with the Accountable Care Act, but it's really the notion behind the Accountable Care Act. We know that there's an increase in access stemming from the bill, and roughly think about that as about 30 million more individuals coming into the system and needing behavioral health services. I think it's well known that 1 in 5 people that actually present with a physical type of ailment or issue also have a co-occurring behavioral health issue. So how do we deal with not only the increase, but this increase in the co-occurring conditions in our population? With the bill, there's notions of care model changes, specifically around collaboration. If you think about the health home, the patient-centered medical home, or just ACOs in general, they represent different care models. And along with that, we've seen different forms of reimbursement change. I think we've seen this in the behavioral health industry as we move from an industry primarily reimbursed through grants into a fee-for-service system, but also, down the line, that also has different changes in reimbursements around this notion of performance or value-based reimbursements, and we'll talk further about that. Along with that is the Parity Act, and I think we got to think about the Parity Act in 2 different planes. Parity does bring up the notion of that you must be able, in the plan design, to be able to offer mental health and behavioral health services in parity to what you get from a medical perspective. But I think we need to think between the lines there in parity, and what does the future of parity really mean to our industry? Not only do we have to be offered at the same level, I think it's good for in organizations in this industry to also start to think that there will be connotations around how do we operate in parity with what's already been going into the market, and that further brings along sort of those reimbursement changes. From a measurement perspective, we're starting to see this meaningful use stage 2 for those that participate. I think that applies to another sense of sort of policy change. But you really need to look at SAMHSA and the Office of National Coordinators and look at what they're also producing out for public comment around different certification standards that align more closely with behavioral health organizations. I think that most of us know now that meaningful use, while it includes behavioral health, the eligible professional definitions don't allow us to enter into that certification as much as you would see from a sort of a physical health provider. So that's really the policy changes. From a behavioral health industry perspective, which really ties into the theme of the webinar today, is this notion of scarcity of resources. So if we know that there's an increased demand really stemming from a policy standpoint, there's a well-documented cases within government resources and other around the real scarcity of professional resources around for licensed clinical social workers, psychiatrists, nurses, and go forth. We're not seeing a rapid increase in the level of professionals available to service that increase in demand. There's service delivery changes, and I think this really is, connected to the policy piece. We've seen health homes, this notion of telepsychiatry, even though not reimbursed across our nation, or it's really in pockets, but this notion of delivery changes. And then provider reimbursement changes, I mentioned this before, it's linked into the policy that we're gradually moving through grants to fee-for-service to this notion of value-based reimbursement. Technology, I think, is an interesting perspective, right? Electronic health records and this notion of mobility is not new, but there's definitely a second generation of a wave of much more modern applications out on the market for behavioral health organizations to really think about and consider. And with their more modern structures and back ends, a lot more capabilities now that sort of make our initial notions of mobility much more reachable for organizations, if that makes sense. There's a focus on not only just delivering functionality, but this improvement of the end-to-end experience. The applications are much more wide now, where they traditionally started out in billing and transcended into clinical applications. Now we think about this whole entire experience of how do we streamline the intake and registration, how do you integrate that information into the clinical and medical management processes, how does that tightly integrate into your billing to make sure that you're capturing the service revenues and also having low denial rates and so forth. And then, I already touched upon this, is with the newness of the platforms, these much more modern technology sort of stacks within the EHR applications and platforms, how do we continue to improve our efficiency and be able to document sort of the results that we're getting? So I think with that understanding, we're just trying to mark out that this is not just a change for change's sake, but there are underlying currents in our industry that are, really forcing or making organizations refocus their service delivery channels. So now that we've talked a little bit about just the setup, what are the trends, what are the driving notions, what's the elements of change in our market, I think the next place that we want to go to is really around, EHR mobility for service channel expansion, and really think about that first. What I wanted to show the audience was an interesting piece of analysis that we did off of the registration for today's attendance. So when we asked you the 3 questions as part of the registration process, what I wanted to show you here was that the interest in mobility is quite high, which is what you see on the left side of the slide. And you're seeing, roughly around 60% of our current audience today in this webinar really is interested in mobility. But part of that story is really on this right-hand side of the slide, where the EHR supports this need for going to mobility, and it's almost a complete reversal, right? 60% of the audience, or a little bit more of the audience, is saying their current EHR, and this goes back to that first generation EHR choices, don't feel like those EHRs can support a mobile, capabilities. So I think from a channel discussion, it's important to understand that, we all want this, but we don't necessarily feel like the platforms in place can adequately do the capabilities that we need to move forward, which is just interesting for us to understand. And it is truly just a sign of the progression of our industry. But with that, so understanding that we all want to make this change, this is not, again, I can't repeat this enough, just a technology change. This is thinking about, when you're thinking about mobile and really introducing it into your workforce, what are the changes in personnel? How do their jobs change? What are the people kind of components of this change that really need to be thought through? Much like you would have thought about your first implementation of your EHR, mobility is no less of an undertaking about how does this change the way I interact with my staff, and therefore how does my staff, change, their interactions change with their clients, which bridges over into processes, right? Mobile technology represents a lot of opportunity, but it doesn't mean that we can take the standard sets and procedures and processes, forms, reports, and workflows, and be able to move them right into a mobile device because of some of the limitations that come along with your device choices, and we're going to get there next. And the last part is technology. How does it complement what you have today? If not complement, how do you add it in as its own application layer and figure out what you do there? to really go, further within your technology. I think when you think about your mobile capabilities, the people that can provide that to you, are they going to be a good technology portfolio partner? Are they going to play well within your organization, and will you be able to utilize it at the level that you've thought so initially, if that makes sense? So with that, it's a people, process, and technology change within your organization. I think the next step after you think about that from your perspective is define what mobility is for your organization, because I think if I've learned anything throughout my time with dealing with mobile applications, mobility means different things to different people, even within your own organization. And so setting up a standard definition of what mobility is for you and your organization is really the first place to start, beyond thinking about globally the technology and process and people changes. So this is how we've defined it. The ability to bring the provider to the client, I think this is, part and parcel to that we have to be able to deliver services beyond the traditional settings. There are certain social stigmas that come with having to go to a formal setting for behavioral health. There are also just different boundaries to care or borders to care that we need to solve for in rural situations, right? Rural, counties don't have all the facility and access. So how do you bring your providers to the clients to render the service they need without having to make them come through the physical limitations of travel and economics and the social stigma? Access to information whenever you need it. Right? Our lives are not planned. I would love to know, and understand when my clients are going to enter into a crisis state, but we don't really understand that. That really is predicted on that particular person's part of their recovery and how they react to their issues. Freedom to interact at a time and a place when we're most comfortable. This brings up the notion of, to be truly mobile, you need to be able to be disconnected. That means you have to be able to operate on a device when there's no internet, without a satellite card, and be able to really take the client's information at that point, be able to save that in the device itself, and then be able to sync up and go back to the holistic record that's hopefully that you have at your headquarters. So we'll talk a lot about this notion of disconnected mobile devices and truly disconnected. And I think that's a learning element I want the whole audience to take away, is when you're investigating these solutions. Again, this is the importance of definition of mobility. Do you want them to be able to work in a disconnected state so that they can service your clients in the most optimal fashion without having contingencies based on technology? And then, technologies that enable us to remain in contact with one another regardless of our location really builds upon the last three themes, but being able to really provide your service from anywhere. Right, based on where that client is, and really take the care to the client, meet them where they are, is really that definition. So hopefully you can see our approach to this, and the importance is really, what is going to be your approach so that you can find the best partner for, your mobility goals. So, once we've thought about our organization, come through and define what mobility means to us, really I think you got to start to think about mobility options. And I have to stress that a standardization within the devices, thinking about your forms, is really appropriate at this level. But we've always had laptops. A lot of them are mobile, and you can get up and do that. I think, each one of these choices really represents, a plus and a minus. A laptop, yes, it gives you a fully functional keyboard. You've got the screen resolution and size to be able to do a lot of things. I think the negative side of that is that it's very big and it's hard to take into the field. It's not, not all of us have these fully functional sort of laptops. If we take a TSS example, when you're providing wraparound services, they may or may not be outfitted with a fully functional laptop, and you may not have aspirations to do that in that given example. I think next are tablets, and I want to tackle tablets and smartphones together since they sort of represent similar opportunities. Tablets are great. We have to understand the expense around them, how many you're going to need, what are the processes that you're going to have for distribution to your staff, and really thinking about the core functionality that you would want in a tablet or a smartphone is something that you're going to have to consider, and also make and model. Are you going to require your vendor and your internal IT staff, depending on your level of capabilities, to have to manage the multiple platforms that these devices run on? So if you're going to pick Apple, you better have, iOS experience and really be able to understand that. If you pick a Microsoft tablet, understanding those support and those different mechanisms there. I think the smartphone really represents a very, small channel for mobility because of its limitation in screen size, but there are unique things that we can do there, like video chats or smart message, texting and things like reminders for appointments. But they certainly have their own limitations. Again, the capabilities inside of it and the lack of a keyboard, you really have to think about what are the forms that are going to be there? What are the types of reports or processes you're going to want to carry forth from there? And we'll get further into that. But at this point, when you're still thinking about your organizational plan for mobility, standardization of device and where you want to render mobile capabilities to is a big consideration. Portals is another kind of mobile capability. I think the bottom two here on the slide really represent the cutting edge of where mobility is headed. So devices, how do we, wear devices? There are certain innovations that are in technology around geo-proximity to places. Let's take, an alcoholic, for example, and we're trying to keep them within their recovery. How do you, if you have a geo-proximity device that tells you that they're near a place where they used to exhibit behavior around their alcoholic symptoms, and that triggers off a call to their support network, those capabilities are starting to, come into market. The next one here on the bottom right is really video chat, and how do we do this telepsychiatry, or even being able to, take it out of the psychology or psychiatry realm, and, what could we do and apply, video chat sessions that would allow us to do intake much faster, or registration, or the initial assessment of a client, and be able to really, utilize those technologies. I think overriding, this point is the device selection and being able to understand what you're going to utilize is not a trivial piece. And the more devices you choose to go out to just means that you need to plan for each one of those channels of delivery, and really have an organizational plan around that. So with all of those pieces now considered and sort of starting out on the process, where we thought and where we've done a lot of analysis on is where is a good fit for mobility. And we've really targeted around sort of, I'll call the first half of our processes, which really are around intake, the ability to schedule the appointment, and service delivery. And then underneath each one of those, we've tried to target very specific functions that are very common within behavioral health organizations. And we're going to, think about, registration, contacts, and insurance and referrals is a pretty easy set of capabilities to extend into a mobile platform. And so is scheduling. Where it starts to get, into additional consideration is really around the service delivery. And the big part around service delivery is really in consideration of, because service delivery is really driven off of forms and being able to document the conversation that's happening with the client. And therefore, you really need to think about all of these levels, the client profile. What are the necessary fields that I would want someone to collect from a mobile application depending on the ones that I choose. My assessments, how do I think through my assessments and all the areas there that I'm going to try to explore with a client, be it my problems, my diagnosis, the medications. And the big one that I would really ask for the audience to think about is your treatment plans. And let's take the iPad, for example. If you're doing a traditional biopsychosocial assessment and with a client, that is an extremely complicated form to really take to an iPad because you got to think, it has no keyboard associated to it, and most technical skill levels are still, using one finger to do the typing. So you really have to think about your forms creation and the mobile rendering of those forms when you think about treatment plans. We have one particular, customer that we're working on that has really taken a recovery service plan and modified it in a way that it is really the essential components that their field workers can, or field staff can administer, and still then sync that back up to the master client record back at their headquarters. So this, these are the general areas that we believe are, applicable in terms of mobility technology. We certainly wouldn't recommend, and I believe the audience would pretty much be there with us, is that the billing, reporting, and outcomes measurement is not intended at this point in time for mobility. It would be really, really hard for the mobile application to handle the complexity of what we're trying to do in the technology set in a mobile setting, if that makes sense. So with that, I think we did some more analysis off the registration page. Logins. And I think, and this is why I feel very comfortable with the audience today. I think we all highlighted, but this is off of your data that you submitted to us, that, the areas we highlighted were generally the areas you're thinking about. So, the biggest part here being, client engagement. How do we extend services to get, clients engaged, be it portals or interactions around the treatment plan? Field service enablement was another big one. Clinical workflows that make sense. Again, we were just talking about how do we administer treatment plans or do the first assessment in those pieces. And then intake and registration, another big area there. So we just wanted to bring forth the data that you're providing to us to just show you a little bit around the validation around thoughts, and that I think we're all approaching this from a very similar perspective, so you shouldn't feel alone out there in terms of how you're thinking about mobility for your organization. So with that, I think, we've covered the trends. We've sort of covered a high-level perspective, and we have a lot of tools that we offer out to our customers to help them think about the organizational change management for service channel expansion. But now I want to turn, the presentation over to Dave Smith to talk you through just this idea of readiness, organizational readiness from a technology standpoint, and how do you build out your foundation of technology so that you can apply the different levels of mobility to the organization.
Thank you, Robert. So as Robert indicated, he talked a bit about the market trends and sort of the services that you could look to offer from a mobile perspective. What I want to talk about now is a roadmap for mobility. And what this first slide shows you is our typical what we call maturity model for behavioral health. And what we've done is overlay on this how you can start to leverage your mobile assets, mobile technology as you progress through the different stages of this maturity model. So what this graph shows is a representation where the y-axis is the extent of automation and the increased performance of the organization. And what we show on the x-axis is the different phases of maturity and increased expansion of behavioral health services. And you can see as you progress from left to right, what happens is the maturity of the organization starts to increase. So in the beginning, the focus is on centralization of data, and this could be many different types of data from client data to financial data, organizational data, et cetera. In the second phase, we start to look into standardization of business processes and business rules. And it's at this phase that organizations will start to see EHR technology being brought into play. As we advance into the third phase of maturity, or the third stage of maturity, which is the integrated behavioral health stage, clinical and billing functions now become fully integrated. The EHR that you may have begun implementing in phase 2 is now fully established, and this is really the phase where mobile technology starts to play a prominent role within the enterprise. As we get into stage 4, the value-based behavioral healthcare stage, this is where the enterprise can leverage the assets of the enterprise to improve outcomes. And this is where mobile technology is really a key asset of the organization. So rather than becoming an enabler, it actually becomes a transformational asset within the organization. And as Robert alluded to before, again, we're talking about mobility in a broader sense here. So it's not just about the technologies that are in play, but also about the setting in which patients and clinicians interact. So what you see from the arrow there is that as we progress up the staircase, you're going to see an increase in the presence of mobile technology. And we're going to dive into each of these areas on the next slides. So phase 1, behavioral health, maturity stage 1, single system data centralization. In this stage, the enterprise is looking to identify, tag, and centralize key information that exists in the enterprise. So a lot of this information might already be captured electronically, but it probably exists in multiple formats. So you'll find data that's captured within Access databases, Excel spreadsheets, Word documents, but very often what you're going to find is that a lot of the data within the enterprise is just captured on paper and stored in filing cabinets in the basement or the attic somewhere. So what we see in stage 1, if you look at the data centralization box up there on the left, is we start to see a decrease in the reliance on paper and an increase in data standardization and data governance. While there's no formal rule system, you will find that very often there are informal rules, and this may be documented in paper policies or procedures that are put in place that describe how data should be captured and stored within these systems. What are some of the key functionalities? Well, obviously, single source of truth, or in many cases, source of truths will be in place. For instance, you may have a separate source of truth around client data and a separate source of truth from billing data, and that's very common of what we'll see in stage 1. As we get later into follow-on stages, you'll see how more mature organizations have brought this data together in a more holistic sense. We start to look at systems for users to input data and define standards. And again, these are typically basic systems that will allow the capture of data without a whole lot of intelligence in place or a whole lot of navigation from the user's perspective. What are the values? Well, again, the electronic capture of data and the reduced reliance on paper starts to give the enterprise the ability to search and retrieve data, and this will lead to reduced cycle times to process information. Standards and governance increase the accuracy of data, and again, while this is limited here, the fact that you can start to require certain fields or give the user lists of data to choose from leads to less variance in how data is captured. And this increases the accuracy of the data. Because things are electronic and not stored in filing cabinets, more patient data is accessible at your fingertips. Things like encounters, appointments, diagnoses, treatments, a lot of this data starts to come together to give you a more holistic view of the client. And again, for some organizations, that will also include financial information. Now, in stage 1, mobility is really only foundational at this point. The capture of the data in electronic format starts to set up the enterprise to begin implementing mobile constructs. Because the data is captured electronically, there is the ability to move data around, which does add a layer of mobility or portability. But again, in phase 1, mobility is in its infancy. So stage 2. We get into stage 2. This is where the organization or the enterprise is really building on the foundation that's been set in stage 1. The goal of this stage is to reduce the variation in processes between users, reduce the administrative cost of the enterprise, increase coordination among clinical and billing professionals, increase the quality of data, and increase visibility. And it's at this stage, as I mentioned before, that the enterprise may actually start using an EHR. So how is this accomplished? Well, what we start to see in stage 2 is the beginnings of the automation of the enterprise. So the sources of truth that we started to define in stage 1, we start to build standard workflows and forms that will guide administrative staff and clinicians through the collection of data in a standardized fashion. So as I mentioned before, these forms now will definitely have predefined values for many fields to limit the variability in data entry. The forms will have standard rules for data validation. It's at this stage that the enterprise begins to develop enterprise intelligence by mining the data through standard reports and analytics. One thing to consider at this stage is flexible designs, and these become key. And what you'll find, every software system will provide standard workflows, forms, fields, rules, reports to allow the users to complete their work. But what you need to look for in software is software that gives you the ability to deviate from the norm. There's always something about every enterprise that is different from the norm, and you need a system that's going to allow you to accommodate those seamlessly within your workflows, forms, reports, etc. What's the value of stage 2? Well, now that there are applications that front the data entry and data reporting functions, information is ready at the push of a button. So any user, whether they're located within the 4 walls of the enterprise or start to bring in remote users, information becomes ready at the push of a button. Because you have proven repeatable processes to guide data entry, the quality of the data is going to improve. And there's a lot of, obviously the quality of the data itself being improved is of value to the organization. But because you have proven repeatable processes, it makes onboarding of new personnel faster and cheaper, which is also a side benefit as well. By having the information they need to make informed decisions, clinicians are now able to increase the quality of care, which, ultimately the whole reason we're all in this business is to improve quality of care. So that becomes a key value at stage 2. And the centralized data and standard workflows improve internal coordination and improve compliance. So what are the mobile building blocks of stage 2? Well, now that the organization has everything in place to begin leveraging mobile technology, but as Robert mentioned, before you jump right in, you need to consider what information and what processes are right for the mobile form factor. And again, depending which of those mobile form factors you choose, the amount of data and the way you present the data could be vastly different. Not all activities are going to be appropriate, nor do they need to be pushed to the mobile device. And not every process needs to be enabled outside of the enterprise. An example you might think about is your monthly billings report. That's not something that necessarily needs to be pushed out to a mobile device. One other thing, you also need to look at whether the same processes that work for your EHR will work in a mobile setting. You need to review and refine your current processes, workflows, and forms, and review the data and fields to minimize the amount of content being pushed down to the mobile device. So when you start to think about technology limitations here and network bandwidth, it's not going to be appropriate to try to push an entire EHR database down to an iPad or an iPhone or utilize features like advanced searches on those devices. They're just not designed for those types of things. And the last thing, and this is probably one of the key things in our industry to think about, is enterprise security and data privacy. So, as we start to move more information out to mobile devices, the security and privacy becomes a high concern. So what's going to happen if somebody loses the iPad that has sensitive data on it? You need to make sure that that data is encrypted and protected to make sure that some individual who finds that iPad doesn't have access to somebody's private information. So now we get into stage 3, which is integrated behavioral health. And in stage 3, the goal becomes integration of care delivery and communication across the enterprise. And this is what we mean by integrated behavioral health. Focus at this stage is going to be less on operational efficiencies. That's what we really achieved in stage 2, and more on integration and collaboration. So what are the goals of stage 3 enterprises? First and foremost, reducing customer churn. And this is achieved by ensuring a consistent experience for the client from beginning to end, and of course the end being successful client outcomes. To accomplish this requires an increase in client engagement, which is actually the 5th bullet that you see there on the chart. If you have clients who are more engaged and take a more active role in their healthcare, you're going to see greater client outcomes. Reduced billing cycle, and this is certainly more of an internal need from the enterprise perspective. But once you've captured everything electronically in the electronic health record, and you start tying that information to the billing system, and this is what I'd referred to before, is that by the time organizations have reached stage 3, all of this information is integrated together within, if not a single system, certainly within a single workflow and single dashboard from the user's perspective. That'll enable enterprises to start billing more accurately, more quickly, and that'll improve revenue cycles. Increasing operability. So Rob talked earlier about the 3 pillars there being people, process, and technology. And the goal here is to increase operability across all 3 dimensions. So you want people talking to people, you want processes that are integrated across the different departments within the enterprise, and you want technology that's going to bring all of those people and processes together. And finally, increased access to data. And here we're going to continue to build on stage 2 by providing greater access to integrated data, increasing the use of analytics to provide feedback to operations so that the enterprise can ultimately achieve their goal of continuous process improvement. So now that the organization has reached organizational and technical maturity, the main aspects of functionality in stage 3 are integrations both within and without the enterprise. So integration between the clinical and billing departments, as we've talked about, and functions becomes one area here. Integrations to third parties for things like the electronic exchange of lab data or electronic ordering of prescriptions is another aspect of integration. Integrations with clearinghouses for exchange of EDI messages. So you think about exchanges of your 835 and 837s. And integrations to other care providers to share information in a patient-centric model. And that seems to be the trend where putting the patient at the center of the model and making sure that all of the different caregivers, whether they're behavioral health or frankly, medical professionals as well, all have access to the same information so that they can ultimately increase the outcomes for that individual. And then from an analytics perspective, dashboards become the primary mechanism for assessing the health of the organization and giving individuals the ability to report on key metrics throughout the organization. So what's the value of achieving stage 3? Well, first and foremost, integration of systems, people, and processes leads to increased care collaboration and coordination, and that will ultimately translate into customer satisfaction. Increased integration with third parties will lead to increased data enrichment. Expanded use of analytics tools and greater use of data-driven decision-making will make increased visibility of data throughout the organization. And the final value of stage 3 centers on outcome measures to support meaningful use initiatives. By stage 3, most organizations will have moved beyond stage 1 and are now ready for the advanced clinical process requirements for stage 2 certification. And so all of the things that we've defined here will support that certification. So where does mobility fit into stage 3? Well, as I talked about on the first slide, at this point the organization's implemented an EHR and is looking to push that functionality out to remote users. Some of these users will not have connectivity. So one of the examples within the behavioral health space, many encounters happen within facilities that prevent wireless internet access. So as Robert talked about, the ability to utilize the EHR in an offline mode to view clinical data, appointments, create notes, becomes critical to relieving these field personnel from the burden of dual entry. And that dual entry being capturing information on paper while they're on site with the client, and then having to transcribe or transpose that into an electronic form when they get back. By having the ability to record the data in front of the client and then syncing it electronically reduces one of those steps. And again, increases their ability or their efficiency in the ability to see more patients because they're not spending their time keying data. So as I said, with that, once the user is reconnected, they can then sync their mobile device with the central application and download any new data to their device. So that brings us to stage 4, stage 4 being value-based behavioral health care. And in stage 4, what happens now is organizations move beyond the 4 walls of the enterprise, and they're really making the patient the central figure in the care delivery and care coordination process. In this stage, organizations focus on reducing gaps in care, increasing the personalization of their care by tailoring it specifically to the needs of the client. One aspect of the increased personalization is an increase in client access to health data via PHRs. And we'll talk about this a little bit later, of this being one of the key focus points for mobility in stage 4. The goal of this increased focus on the client is to drive an increase in client engagement with an ultimate goal of increasing patient outcomes. In stage 4, the functional focus is on providing tools for greater client interaction. And as I said, mobile technology in particular becomes more prominent in delivering the functionality, and we'll discuss that in a little bit. Functionality that increases client engagement and communication, be that written or verbal communication, also become paramount to success for stage 4 organizations. And finally, real-time information improves decision-making by ensuring both patient and clinician are basing decisions on the most up-to-date information available. So what's the value of achieving stage 4? Well, one value is increased access to care. One of the mobile strategies we talked about is secured communication via audio and video. And this real-time communication means that clients will have increased access to care when and where it is needed. Within behavioral health, this could mean access to speak with a trained professional at times of crisis, which is when the care is most needed. And this is what we mean by treatment delivery beyond the traditional setting, right? Taking that treatment delivery out of the office setting to an environment where the client feels more comfortable. And once that client-clinician relationship's been established, ongoing care can be delivered in a remote setting, which enables clients and clinicians to maximize the use of their time. Reducing delay or double data entry. So providing applications that extend into the field and to clients means that data only has to be captured once. And again, whether this is the client filling out a form or the clinician capturing data, either of these can be done electronically once and potentially verified, and then becomes available for general consumption. So as I mentioned earlier, stage 4 is where mobility really has the greatest presence. Stage 4 enterprises look to establish a patient portal for patient interaction. And again, a simple example here would be requesting of services, but this portal could also be used for displaying appointments, providing links to other valuable information that will help in the care of the client, displaying billing information, posting reminders. Again, any information that the enterprise has that would be of value to the client is something that we could expose through this patient portal. A portable patient health record that follows the patient. So once we start collecting all of the information within the EHR, the patient now has access to a PHR that they can take with them when they go beyond this clinician and have to see other healthcare providers, again, be those behavioral health or medical practitioners as well. And an increase in web and smartphone-based applications. And these are applications both for the clinician, so we talked about mobile EHR, as well as applications for the patient. That could be the mobile PHR or secure communication via audio and video, as we discussed earlier, to provide real-time client access to clinicians. So in summary, what we've talked about today here is there's an increased demand and scarcity of resources, and that's going to require behavioral health organizations to think about the way they deliver care and deliver service in a different way. And that could be automation to simply reduce administrative costs and to reduce cycle times to be able to get more work done. It could also be the way you start to think about how you provide access to clients. Again, whether that's a mobile access to their PHR, or whether that's mobile technology for real-time client-clinician interaction via video or voice. Mobility is not a resource replacement. So hopefully one of the key points you got from the presentation was that mobility is an extension of what you're already doing. It extends your ability to provide services to more clients. But if you don't have all of the building blocks in place, whether those building blocks are your centralization of data, automated processes, rules, reports, data analytics, mobility is not going to achieve the goals that you've set out for it. As Robert talked about, mobility means a lot of things. The first thing you need to figure out is, what does it mean to your organization? So is mobility just a state of mind, or is mobility the assets that you utilize to bring your patients and your clinicians closer together? And finally, you have to create a strong EHR foundation. The EHR begins with, as I said, the collection of data and the standardization and the data governance, and then you phase in your mobile approach as appropriate based on the level of change management within the organization. So with that, that concludes our presentation, and I guess we'll turn it over to questions at this point.
Okay, great. Thank you both for a very informative presentation. We have had a number of questions from the audience come in throughout that, but we would like to remind everybody to use that Q&A widget below the slides on your screen to submit a question at any time. We will continue to take those questions. So I think for the first one, Robert, you talked a little bit at the beginning about a truly disconnected mobile capabilities. Can you just expand on that a little bit and maybe explain a little bit more?
Sure, and I apologize because I want to be able to have Dave add in pieces here. So we've switched over to the speakerphone, so we're going to talk a little bit closer to the phone. There's a lot of ways to render mobile capabilities, but like Dave mentioned and I also talked about, there are certain settings that just don't allow those capabilities to be set. If it's in a school, sometimes schools don't have wireless connections. So what do? If you're in a correctional facility, those buildings are structured in a way that doesn't allow mobile capability for obvious reasons. And then you just go out to plain rural settings, right? I think it's a misnomer that everyone has an internet connection that we can get to, but we still need to provide services. So what does that really mean from a disconnected sense of mobility? If you're going to be able to work on an iPad, being able to work with it untethered to an internet connection means that you have to have a device that's capable of storing that information locally, which also stems into the way that you think about your mobile sort of security parameters, what kinds of processes you're going to set in place for synchronization of data, those things. But when we say disconnected, it truly means that. It's not tethered or contingent on being able to do the work based on an internet connection. So really being able to use that device, again, as a surface channel extension in the natural way that it takes place. Having a satellite card or having a wireless card is not always the natural way that these things would take place. So that's what we mean by disconnected. Hopefully that helps. Dave, would you add?
No, I think that summarized it quite well.
Okay, great.
Okay, great. Thank you. Another thing someone wanted clarification on was just, you talked at the beginning a little bit, Robert, about the certain areas where mobility is currently at, and you said it's not currently going to billing, reporting, and outcomes. And somebody was just wondering, do you see mobility eventually expanding to include these areas, or what needs to happen in order to make that possible?
Well, and here's where, and I don't want to be flippant in my response, but I think we got to start with the question of why, right? I think any technology application has to start out with the why. Why would we want to carry out billing in a rural setting or in a correctional facility or those kinds of things? Because I want you to think about that. It's not that you can't render a billing process on a mobile device. Will the mobile device allow you to do the printing of a statement? Are you going to carry around a Bluetooth printer, to print out a client statement, or print off an e-prescription because there is no local, let's just say CVS, and they need to carry it to a pharmacy, in the hand? I think that's why I would ask the question of why. It's not that we can't bring mobile technology, around billing or reporting out. It's, can the mobile device at its current level support what you need to do? That's why we think that, intake, scheduling, clinical processes makes a lot of sense right now. Not saying that billing won't sometime in the future, but let's think about the complexity of what we're trying to do when we do billing or reporting out. Dave?
Yeah, I think the only thing I would add there is it's also, ROI, right? We're all running businesses with, tight budgets. There are certain activities, and we've talked to, a lot of them, certainly the clinical aspects, where there's a high return on investment to enable those processes via mobile technology. The return's probably not there from a billing perspective. You have a select group of users who probably aren't out in the field anyway that do the majority of the billing work. To just have access to their core systems to do that work is probably sufficient, and you're not going to get a whole lot of return on those additional investment dollars to mobile enable those processes.
And the only part I'd add there is when we think about, again, this is where mobile device consideration really takes into play. If you want to do billing on a laptop, I think, okay, we can do that. And if you're trying to think about from a home setting, this person doesn't need to come into the office all the time. Agreed. And you should be able to do that within your current EHR. At least we expect that should be able to be done. But when you traverse into the little higher levels of order of mobility devices, that's when I think, billing and reporting become something that needs to be critically thought through.
Okay, great. Thank you both so much. We have somebody wondering about personal phones. So the question is, should an agency allow employees to utilize their personal phones to access protected health information? And, they're just wondering about this because they said their understanding with the HIPAA standards is that, mixing this type of information on a personal phone is not a good idea because of the risks involved. So what are your thoughts on that?
It's probably one of the hottest topics around mobility. In and of the functionality itself is this whole notion of bring your own device, the BYOD acronym. And I'm going to let Dave take a crack at it. He's going to give you a technology point of view. I can kind of give it from a organizational standpoint, but I think you start with the technology.
Yeah, and there's certain industries where it makes sense to provide that, and I think even within behavioral health, right? Again, are we talking about the client or the clinician? If it's the client utilizing their own device, obviously that's fine and appropriate, and they're assuming their own risk for the safety and security of their information, just like any user needs to. You need to make sure that your password to your bank website is secured so that you don't lose data. When you start looking at the clinician, though, the bring your own device starts to put a lot of liability on the enterprise. And as I talked about, security and privacy being so key, particularly in the healthcare industry, the enterprise assumes a lot of liability if that individual loses that device. If the enterprise has provided the device, they're going to provide the security mechanisms to make sure that even if the device is lost, they can either remote wipe the device or they can certainly would have encrypted the data in the first place. If it's a user's own device, oftentimes those those capabilities aren't available. And so by allowing your clinicians to utilize their own device, you as an enterprise are really assuming a lot of liability that's probably just not worth it.
Yeah, and I just echo Dave's comments there. From outside the technology standpoint, it's the consideration around your security, your policies, your standards, synchronization of data policy, all of those things. I think when you do a BYOD or bring your own device, you're contemplating that. You're, if this makes sense, upping the ante in your complexity around, what do you want to make available through those devices, and what processes do you need in place to have the controls that you can be assured that you have HIPAA compliance. That's probably where I'd leave it.
Okay, sounds great. Thank you both so much. That is all of the time we have for questions today. I want to again thank both David Smith and Robert Capobianco for an excellent presentation. I would also like to thank our sponsor, Core Solutions, for making today's program possible. Finally, thank you to you and our audience for participating today. We hope you'll join us in the future for another behavioral healthcare webinar. This concludes today's presentation.